medication-induced sexual dysfunction. And part 2 is the gender dysphoria, and part 3 is the paraphilic disorders. Okay, next slide, please. So before we get into the sexual dysfunction, I would like to introduce regarding the normal sexual response cycle. So in the sexual intercourse, there would be 4 stages that occurs. The first stage is the desire, which is the motivation or interest in the sexual activity, often reflected by the sexual fantasies. And the stage 2 is the excitement or also known as the arousal, which is begin with the sexual fantasies or the physical contact. In the male, there would be a physiological sign of erection and testicular enlargement, and in female, there would be vaginal lubrication, clitoral erection, labial swelling, and also elevation of the uterus. And both of the gender will have the flushing, nipple erection, increase in the respiratory rate, pulse rate, and also the blood pressure. And then there will be sexual intercourse, and stage 3 will be the orgasm, in which the men will presented with ejaculation, and women will have a contraction of the uterus and lower 1/3 of the vagina. For both gender, there will be facial grimacing, release of the tension, slight clouding of the consciousness, involuntary anal sphincter contraction, and also the acute increase in the blood pressure and also the pulse rate. And stage number 4 is the resolution. Both gender will have muscle relaxation, return of the cardiovascular state to the baseline, which is reduction in the pulse rate and also the blood pressure, and detumescence of the genitalia. For the men, there would be minutes to hours of the refractory period, in which they cannot experience the orgasm again. And then women will have little or no refractory period. So sexual dysfunction by definition is the problems involved in any stage of the sexual response cycle that I have mentioned before. And according to the ICD-10, it stated that the sexual dysfunction is the person's inability to participate in sexual relationship as he or she could wish. Okay, next slide, please. So moving on to the male sexual dysfunction. Next slide. The first disorder I would like to talk about is the male hypoactive sexual desire disorder. So the features are the deficiency or absence of the sexual fantasy and desire, which is the first stage in the normal sexual response cycle for sexual activity for a minimum duration of approximately 6 months. So the approximately is important in this condition in which there is no actual cutoff point. We take the approximate time span. So for the clinical manifestation, the man can have the non-initiation of the sexual intercourse and also lack of the receptivity to the partner initiation. The associated features are the erectile and also early ejaculatory concerns, in which this can happen when there is a persistent difficulties obtaining an erection, causing the man to lose interest in sexual activity. So the comorbidities such as the depression, erectile disorder, and also the early ejaculation disorder. Next slide, please. So for the risk and prognosis factor, one of the risk factor is the temperamental, in which the patient can have depression or anxiety. So if we remember, one of the criteria for the depression is the loss or diminish in the pleasure or interest in the daily or almost all activity. Therefore, this can explain that why the men have the reduced sexual desire. And also the man's perception about himself, his partner, sexual desire towards him, the feeling of being emotionally connected, and also the contextual variables. For the environmental factors, the alcohol use can lead to the low sexual desire in men, and among the homosexual men, the self-directed homophobia, interpersonal problems, attitudes, lack of adequate sexual education, and also the trauma resulting from early life experiences could lead to these disorders. And the stressors such as the job loss and also the bereavement, the cultural or religious factors such as the inhibition related to prohibitions against sexual activity, attitudes toward the sexuality. And for the genetic and physiological factors, the endocrine disorders such as the hyperprolactinemia can lead to the low desire in men, the age such as the advancing age, the hypogonadism, and also the below critical level of the testosterone. For the partner factors such as the sexual or health problems in the partner can lead to the low desire. the relationship factors such as the poor communication, discrepancy in desire for sexual activities, and also the individual vulnerability factors such as the poor body image, history of the sexual or emotional abuse, all can contribute to these disorders. Next slide, please. So this is the diagnostic criteria for the disorder. The A is the persistently or recurrently deficient or absent sexual or erotic thoughts or fantasy and desire for sexual activities. The judgment of deficiency is made by the clinician, taking into account factors that affect the sexual functioning, such as the age and also the general and socio-cultural context of the individual life. So the criteria B state that the symptoms in A have persisted approximately at least 6 months. And criteria C state that the symptoms in A cause the clinically significant distress in the individual. And the D that criteria D state that the sexual dysfunction is not better explained by non-sexual mental disorders or as a consequence of severe relationship distress or other significant stressor and is not attributable to the effect of a substance or medication or another medical condition. So for your information, the criteria A is the defining features for the disorders, and criteria B, C, D would be repeating for every other sexual dysfunction. For the specifier, we can have the duration, which is the lifelong, in which the disorder happens since the individual becomes sexually active. And acquired means that it began after a period of the normal sexual function. And it could be generalized or acquired. Generalized means that there is no limitation to the situation, such as the certain stimulation, situations, or partner. And acquired means that it happens with certain stimulation, situation, or partner. For the severity, it could be divided into 3 categories: the mild, moderate, and severe. And it depends on the distress caused to the patient. In severe, there would be severe or extreme distress caused towards the patient. Next slide, please. So for the differential diagnosis, which is stated in the criteria D, we need to exclude the differential diagnosis before we come to the diagnosis of the disorder. So number 1 is the non-sexual mental disorder, which is the MDD. So one of the criteria states that there is markedly diminished interest or pleasure in all or almost all activity, also known as anhedonia. And number B, second differential diagnosis is the substance and medication use, in which this will be explained by my teammate later on. Another medical condition such as hypogonadism, diabetes mellitus, thyroid dysfunction, and also the central nervous system disease. And also the interpersonal factor, which is the severe relationship distress between the partners. All right, moving on. So the second disorder is the erectile disorder, in which there is difficulty in obtaining, maintaining erection or decrease in the erectile rigidity. For the prevalence, it is the most common sexual dysfunctions in male, and there is less than 1% of the male younger than 35 years old having this problem, and the incidence increases with age. The associated features are low self-esteem, low self-confidence, decreased sense of masculinity, depressive affect, fear and avoidance of future sexual intercourse, decreased sexual satisfaction and desire of individuals' partners. It can be comorbid with severe MDD, anxiety disorder, and also other sexual diagnoses, such as the diagnosis before the male hypoactive sexual desire disorder, premature ejaculation, and also other medical condition. Next slide, please. So for the risk and prognosis factor, it could be divided into 2. The temperamental factor is more associated with the neurotic personality traits, submissive personality trait, alexithymia, which is the deficit in the cognitive processing of the emotion, depression, and also post-traumatic stress disorder. For the cause modifier, the age, which is the advancing age, the smoking, lack of physical exercise, diabetes mellitus, decreased desire can all contribute to the erectile dysfunction. For the functional consequence, due to the erectile dysfunction, it will be interfere with the fertility, in which they wish to conceive, but then due to the disorder, they are failed to form the further family. And individual and interpersonal distress causing to the patient and also the partner, fear and avoidance of the sexual encounter, and also interfere with the ability to form an intimate relationship with the partners. Next slide, please. So for the diagnostic criteria, criteria A is the defining criteria, in which there will be at least one of the 3 following symptoms experienced on almost all or all occasions, approximately 75% to 100% of the occasion of the sexual activity, either in identified situational context or in generalized. Identified situational context in which there is it could be with the same gender, or it could be with the different gender or different partner. So the symptoms are marked difficulty in obtaining an erection during sexual activity, or marked difficulty in maintaining an erection until the completion of the sexual activity, or there is marked decrease in the erectile rigidity. For the criteria B, C, and D, it is repeated as before. Criteria B is the symptom has persisted for minimum duration of approximately 6 months. Number C is in which the disorder causing the clinical distress to the patient. And D is that we exclude other non-sexual mental disorder, we exclude the severe relationship distress, and we also exclude other substance or medication induced disorder. For the specifier, similarly, it can be specified into lifelong or acquired. Lifelong since the patient becomes sexually active, and acquired after some time of the normal sexual function. Generalized, not limited to the stimulation, situation, or partners. Acquired, related to the stimulation, situation, and partner. And severity, mild, moderate, and also severe. Next slide, please. So for the differential diagnosis, we exclude the MDD, the non-sexual mental disorder, and we also exclude the normal erectile function in the man with excessive expectation towards himself, and also another medical condition such as the more generalized and another medical condition in which it happened more generalized and gradual in onset, except the traumatic injury to the nervous innervation of the genital organ, such as that happened in the spinal cord injury, in which the disorder will be happens more sudden and more rapid. Medical conditions, example are dyslipidemia and cardiovascular disease, hypogonadism, multiple sclerosis, diabetes mellitus, and other diseases that interfere with the vascular, neurological, or endocrine function that required for the normal erectile function. And other sexual dysfunction coexist with the premature ejaculation and male hypoactive sexual desire disorder. Next slide, please. So the third disorder is the premature or early ejaculation. The definition is that the ejaculation prior to or shortly after the vagina penetration. For the lifelong premature ejaculation, the cutoff time that we use is the 60-second intravaginal ejaculatory latency. So in this disorder, the associated features are decreased self-esteem, the sense of the lack of control, adverse consequence of partner relationship, personal distress in the sexual partner, decreased sexual satisfaction in the sexual partner, difficulties in conception due to when the disorder happened prior to the penetration, and also the erectile problem. Next slide, please. For the risk and prognosis factor, under the temperamental factor, the men with anxiety disorder, especially the social anxiety disorder, have higher incidence in developing this kind of disorder, genetic and physiological, such as the dopamine transporter gene polymorphism or serotonin transporter gene polymorphism. The thyroid disease, prostatitis, and drug withdrawal are associated with acquired early ejaculation. Next slide, please. So for the diagnostic criteria, the A and B is the defining criteria. The A is the persistent or recurrent pattern of ejaculation occurring during partner sexual activity within approximately 1 minute, the 60-second, following the vaginal penetration and before the individual wish it. Although the diagnosis of early ejaculation may be applied to individuals engaged in non-vaginal sexual activity, specific duration criteria has not been established for these activities. And the criteria B state that the symptom in criteria A must have been 6 month duration and must be experienced on almost all or approximately 75% to 100% occasion of sexual activity in identified situational context or in generalized in all contexts. And number C and D, same as before, we ask the disorder causing the clinically significant distress, and we exclude other disorders. For the specifier, it could be lifelong, acquired, generalized, and acquired. So for the severity, there is some differences from the before. The mild severity means that the ejaculation occurring within approximately 30 seconds to 1 minute of vaginal penetration. Moderate means that the ejaculation occur within approximately 15 to 30 seconds of the vaginal penetration. And for the severe, it means that the ejaculation happened prior to the sexual activity, at the start of the sexual activity, or within approximately 15 seconds of the vaginal penetration. Next slide, please. For the differential diagnosis, we exclude the substance or medication-induced sexual dysfunction, and we exclude the normal ejaculatory latency, which is longer than 1 minute, but the patient desire the longer ejaculatory latency. And the males with episodic premature ejaculation, in which it happened during the first sexual encounter with the new partner, which could be normal. So the fourth is the delayed ejaculation. It is also known as the retarded ejaculation. It is defined as the difficulty or inability to ejaculate despite of the adequate sexual stimulation and desire to ejaculate. The diagnosis is usually by the self-report of the individual, as there is no precise definition of the delay. And it is rarely present with masturbation, but it is a problem during the partner sex. The associated features are the prolonged thrusting to achieve the orgasm, which lead to the exhaustion of the partner's genital discomfort and ceasing effort. And the men will start to avoid the sexual activity, and it is also comorbid with the severe MDD. And it is the least common male sexual complaint. The incidence much lower than the premature ejaculation and also the erectile dysfunction. The prevalence is 75% of men report ovulating during the sexual activity. However, less than 1% has the problem with this, and the problem lasts greater than 6 months. It is more prevalent in men aged greater than 50 years old. It is due to the age-related loss of fast-conducting peripheral sensory neuron and also age-related decreased sex steroid secretion. For the functional consequence, it will lead to the difficulties in the conceptions and also the psychological stress in one or both of the partners. Next slide, please. For the diagnostic criteria, criteria A stated that either of the following symptoms must be experienced on almost all occasions, approximately 75% to 100% of partner sexual activity. So the keyword here is the partner sexual activity, and in identified situational context or if generalized in all contexts, and without individual desiring delay. So the symptoms are marked delay in ejaculation or marked infrequency or absence of ejaculation at all. So BCD is the same as before, and the specifier are lifelong, acquired, generalized, acquired, mild, moderate, and severe, as mentioned before. Next slide, please. So for the differential diagnosis, we need to exclude another medical condition, and there is an interruption of the nerve supply. The hypogastric nerve is responsible for the sympathetic innervation of the genitalia, and the pudendal nerve is responsible for the parasympathetic innervation. So when there is an interruption to this nerve supply, such as that happened in the traumatic surgical injury to the lumbar sympathetic ganglia, abdominal peritoneal surgery, and lumbar sympathectomy, therefore the delayed ejaculation can happen. And neurodegenerative disease affecting the nerve, such as the multiple sclerosis, diabetic neuropathy, alcoholic neuropathy, need to be excluded. Retrograde ejaculation, which is the ejaculation into the bladder, this can happen following the transurethral resection of the prostate, the TURP. Therefore, we need to elicit the surgical history in this patient. And substance or medication usage will be explained further by my teammate. The example are antidepressant, antipsychotic, alpha sympathetic drug, and also the opioid drug. Therefore, we need to ask during in the drug history. So that's all for my part. I will pass the mic to my teammate.
Continue with female.
Hello, can you guys hear me?
Yes.
Okay, I'm Alia. I will present using Ainul's account because I cannot enter using my account. Okay, so anyways, I will present about female sexual dysfunction and also substance and medication induced this sexual dysfunction. Next. The first female sexual dysfunction is female orgasmic disorder, or it is called as inhibited female orgasm or anorgasmia. So it is defined as recurrent or persistent inhibition of female orgasm, and it is manifested by recurrent delay or absence of orgasm after a normal sexual excitement phase. So usually the clinician will judge to be adequate in focus, intensity and duration, and the woman inability to achieve orgasm by masturbation or coitus. Okay, so the prevalence rate for anorgasmia is 10 to 42% depending on the multiple factors like age and also and approximately 10% of women do not experience orgasm through and dysfunction in some female may have genetic basis and cannot be attributed solely to the physiologic differences. So the risk and prognostic factors for temperamental, anxiety and concern about pregnancy can interfere with a woman's ability to experience orgasm. So in environmental, the socio-cultural factors are also important influence on the experience of orgasmic difficulties, and also genetic and physiological like medical condition and also medication like the SSRI, the antidepressant, can delay or inhibit the orgasmic function in women. So next. This is the diagnostic criteria for anorgasmia. So criteria A, the presence of either one or more of the following symptom and experience on almost all or all approximately 75 to 100% occasion of sexual activity in identified situational context or if generalized in all contexts. Like the first one is marked delay in and marked infrequency or absence of orgasm. And number two is markedly reduced intensity of orgasmic. So B, symptom in criteria A have persisted for a minimum duration of approximately 6 months. And criteria C, the symptom in criteria A cause clinically significant distress in the individual. And the criteria D, the sexual dysfunction is explained by a mental disorder or as a consequence of severe relationship distress or other stressor and is not attributable to the effect of a substance, medication or another medical condition. Next. So these are the specifiers. We have to specify whether it is lifelong or acquired. So as for the lifelong, the disturbance has been present since the individual becomes sexually active. And as for acquired, the disturbance has begun after a period of relatively normal sexual function. So means that the acquired, they get it after they have normal sexual function lah. So specify whether it is generalized or situational. Generalized is not limited to certain types of stimulation, situation or partner. But in situational, it only occurs in certain type of stimulation, situation or partner. And we also have to specify if the patient have never experienced an orgasm under any situation, and must specify the current severity in mild, moderate or severe. So we have exclude any relationship problem, substance use, another medical condition and another psychiatric illness. Next. The next one, the second one is the female sexual interest or arousal disorder. So the low sexual desire is the most common sexual problem reported by women, and women experiencing sexual dysfunction may be associated with inability to feel interest or arousal, infrequent sexual activity, difficulty achieving orgasm, or experience pain during subjective sense of arousal is often poorly correlated with genital lubrication because women complaining of lack of arousal may lubricate vaginally but may not experience subjective sense of excitement. Okay, next. The clinical symptoms are decrease or paucity of erotic feelings, thoughts or fantasies, decreased impulse to initiate sex, decrease or absent receptivity to a partner overtures, and inability to respond to a partner's stimulation. And the risk factor, it depends on the partner factor like the partner's health, partner's sexual problem, and the sexual factors like if they have poor communication, individual vulnerability factor, if they have sexual or emotional abuse before, the psychiatric comorbidity like depression or anxiety and any stressor, And then cultural or religious factor and also medical factors relevant to the prognosis, course, treatment. Next. The diagnostic criteria for criteria A, the patient has lack of or significantly reduced sexual interest or arousal as manifested by at least 3 of the following. The first one is absent or reduced interest in sexual activity. Number 2 is absent or reduced sexual or erotic thoughts or fantasy. Number 3, no or reduced initiation of sexual activity and typically unreceptive to a partner's attempt to initiate. Number 4, absent or reduced sexual interest, excitement or pleasure during sexual activity in almost all or all approximately 75 to 100% sexual encounters. So in identified situational context or if generalized in all contexts lah. So number 5, they have absent or reduced sexual interest or arousal in response to any internal or external sexual or erotic cues. Okay, and then number 6 is absent or reduced genital or non-genital sensation during sexual activity in almost all or all sexual encounters. So the criteria B, C and D is same as before. Next. So we also have to specify whether it is lifelong or acquired, and it is generalized or situational. Situation means that it only occurs in certain types of stimulation situation or partner, and specify the severity, mild, moderate or severe. Have to exclude any relationship problem, substance use, another medical condition and another psychiatric illness. Next. Okay, the third one is genitopelvic pain or the penetration disorder. So in short, the pelvic floor muscle involuntarily contract or tighten whenever there is an attempt to penetrate and it will prevent the penetration. So it is divided into two, dyspareunia and vaginismus. So as for dyspareunia, it is defined as recurrent or persistent genital pain occurring before, during or after intercourse. It causes women to contract their pelvic floor muscle involuntarily. Okay, so we must rule out any somatic causes or lack of lubrication, and the pain is real and makes intercourse unpleasant or unbearable. And if the partner proceed with intercourse regardless of the woman's state of readiness, it can aggravate the condition, the dyspareunia. And then it has increased reported dyspareunia in postmenopausal and immediate postpartum women, but more complaints received from premenopausal women. So the causes of dyspareunia can be because of history of rape or childhood sexual abuse and any tension or anxiety about the sex act, like in the religious factor lah. So vaginismus is actually a constriction of the outer third of the vagina due to involuntary pelvic floor muscle tightening or spasm. It can interfere with any penile insertion or any intercourse, and also if the patient is trying to do a pap smear examination when to insert. So we must exclude any organic factors or symptom of another vaginismus is when no penetration of the vagina, while less severe vaginismus can make penetration but difficult. But it is not impossible to insert any penis, finger or speculum or anything lah. So most often afflicts comes from highly educated women, high socioeconomic group, sexual trauma from the anticipation of pain at first coital experience, and any strict religious upbringing. So next. The diagnostic criteria. The A is persistent or recurrent difficulty or more of the following. So vaginal penetration during intercourse, like the second one is marked vulvovaginal or pelvic pain during vaginal intercourse or penetration attempts. So they feel pain during any intercourse or penetration lah. And then the third one is marked fear or anxiety about vulvovaginal or pelvic pain in anticipation of, during or as a result of vaginal penetration. And the fourth one is marked tensing or tightening of the pelvic floor muscle during attempted vaginal penetration. So it must persist approximately 6 months, and it causes clinically significant distress in the individual. And D, the sexual dysfunction is not better explained by a non-sexual mental disorder or as a consequence of severe relationship distress or another significant stressor, and is not attributable to the effect of a substance or medication or another medical condition. So the specifier can be lifelong or acquired, and the severity can be mild, moderate or severe. Next. Okay, so for management of sexual dysfunction in female, so pharmacotherapy, there are some medication can be given like sildenafil. It can result in vaginal lubrication, but doesn't increase the desire. So cream incorporating prostadil can vaginally applied to increase vasocongestion and subjective sense of and PTSD patient following any rape. Dopaminergic agents can increase libido and improve sex function. The hormone therapy and anti-androgen and anti-estrogen. So as for psychosocial treatment, the patient can undergo any dual sex therapy, specific techniques and exercises, behavior therapy, mindfulness, group therapy, hypnotherapy, and analytical oriented sex therapy. Next, please. So the next one is substance or medication-induced sexual dysfunction. So it is diagnosed when there is evidence of substance intoxication or withdrawal is apparent from the history, physical examination or laboratory findings. And the disturbance in sexual function must be predominant in clinical picture. So any distressing sexual dysfunction occurs soon after significant substance intoxication or withdrawal or after exposure or change of medication. So drug abuse in small dose can enhance sexual performance by decreasing inhibition or anxiety or by causing temporary elevation of mood, while prolonged drug abuse can cause erectile engorgement and orgasmic and ejaculatory capacities become impaired. So the prevalence of substance and medication-induced sexual dysfunction in 25 to 80% individual taking monoamine inhibitor, tricyclic antidepressant and serotonergic antidepressant combined report sexual side effect. And 50% individual taking antipsychotic medication will experience adverse sexual side effect, and 60 to 70% heroin abuser will have sexual problem. And also chronic alcohol and nicotine abuse are related to higher rates of erectile dysfunction. Next, please. So these are example of substances side effect on sexual drive, like the sedative, anxiolytics, hypnotics, opiates and opioids can depress desire of sex. And then alcohol can foster the initiation of sexual activity by removing inhibition but impairs the performance. And cocaine and amphetamine have of increased energy, so they have increased sexual drive lah. And medication side effect on sexual drive for men, usually medication can decrease sex drive, erectile failure, decrease volume of ejaculate, and delayed or retrograde ejaculation. And in women, can cause decreased sex drive, decreased vaginal lubrication, inhibited or delayed orgasm, and decreased or absent vaginal contraction. Next. So these are the diagnostic criteria for substance and medication-induced sexual dysfunction. For criteria A, a clinically significant disturbance in sexual function is predominant in the clinical picture. So criteria B, there is evidence from history, physical examination or lab findings of both 1 and 2. So the first one is the symptom in criteria A developed during or soon after substance intoxication or withdrawal or after exposure to a medication. And the second one is the involved substance or medication is capable of producing the symptoms in criteria A. So for criteria C, the disturbance is not better explained by a sexual dysfunction that is not substance or medication induced. Such evidence of an independent sexual dysfunction could include the following. Means the symptom precede the onset of a substance or medication use. The symptoms persist for a substantial period of time after the cessation of acute withdrawal or severe intoxication, or there is other evidence suggesting the existence of an independent non-substance or medication-induced sexual dysfunction, like any history of recurrent non-substance or medication-related episode. So the criteria D, the disturbance does not occur exclusively during the course of a delirium, and for criteria E, the disturbance cause clinically significant distress in the individual. Next. So these are the specifier. We have to specify whether it is with onset during intoxication, or with onset during withdrawal, or with onset after medication use. So with onset during intoxication, if the criteria are met for intoxication with the substance and the symptom developed during intoxication, for specifier with onset during withdrawal is if the criteria are met from the substance and the symptom developed during or shortly after withdrawal. And with onset after medication use is when symptom may appear either at initiation of medication or after a modification or change in use of medication. So we have to specify whether it is mild. If it is mild, it occurs 25 to 50% of occasion of sexual activity. In moderate, it occurs 50 to 75% of occasion of sexual activity, while in severe, occurs 75% or more occasion of sexual activity. Next, please. So these are the table that I have simplified for you guys. So I will briefly explain it to you. So for antipsychotic medication, example like chlorpromazine, trifluoperazine can impair erection and ejaculation. So it can cause seminal fluid backs up into the bladder and can feel pleasurable sensation but dry orgasm. Means that the sperm goes back into the bladder, and when the patient urinate, it will go out with the sperm, and the urine will be like whitish color. And then for antidepressant, for tricyclic and tetracyclic antidepressant, it can interfere with erection and delay ejaculation. So it can increase sensitivity of the glands with no erection problem, but delay and sometimes can cause painful ejaculation. For type B inhibitor and bupropion can increase sex drive. Venlafaxine and SSRI can cause lower sex drive and difficulty reaching orgasm. And trazodone can cause priapism, means there are prolonged erection in absence of sexual stimuli. So as for lithium, it can reduce hypersexuality and impair erection. Sympathomimetics like amphetamine can cause increases libido, but with prolonged use, men may experience loss of desire and erection. So alpha and beta adrenergic receptor antagonists can cause impotence, decrease volume of ejaculate, and produce retrograde ejaculation. And anticholinergic can reduce vaginal fluid and erectile disorder. Next. So these are some more. Antihistamine can cause inhibit sexual function and delay orgasm. Anti-anxiety, the benzodiazepine can cause improve sexual function because the patient does not have any anxiety to do any sexual activity. So the alcohol can cause erectile disorder in men and increase libido in women. The opioid like heroin can cause erectile dysfunction and decrease libido. Hallucinogen can enhance sexual experience but also can cause psychotic symptoms that can interfere with sexual function. And cannabis and barbiturates both can enhance the sexual pleasure. Okay, that's all from me. Thank you.
Okay, so finish the first section of our presentation today, which is sexual dysfunction. So various the important point because there is many disorders lah, tapi what you need to remember is one, the sexual dysfunction is based on the phase ataupun stage of the sexual intercourse. So that's easy to remember lah. Okay, so start with desire, D, O, orgasm, E is erection, and R is resolution, Dior. doer, okay. So and it divided into male and female. One, okay. In psychiatric view, uh, we just focus that in the management, we just focus on the psychological cause for the sexual dysfunction. Okay, don't ask me about the management of sexual dysfunction, because the main management will go to either family medicine in terms of sexual man or female sexual health, or maybe surgical punya discipline. So we just manage the psychological part of the sexual dysfunction. Okay. For the psychological part, the first is we need to identify whether there is organic or psychological part, and usual treatment is about cognitive behavior therapy or psychodynamic psychotherapy. So that is the common management lah. But I have no experience in managing the patient with sexual dysfunction lah. Maybe we have limited numbers of patients coming to psychiatry lah. They will manage at the FMS, or they will co-manage there lah. Okay. Okay, the next is about the medication-induced sexual dysfunction. Either increase the sexual ataupun reduce causing the sexual dysfunction. When we get the patient with sexual dysfunction, so need to go through their medication, whether they are on chronic medication or taking the illicit substance lah, because some of the medications can induce the sexual dysfunction, and need to go through lah. Otherwise, if we continue to manage without considering the medication used by the patient, maybe we haven't achieved the target in terms of management lah. It's not successful. Okay. So that's for the first part. We move on to the gender dysphoria, the second part. Okay, continue.
Assalamualaikum and good morning to Dr. and fellow colleagues. Next, I will be presenting on the second part of the seminar, which is gender dysphoria. The term gender dysphoria was previously known as gender identity disorder in previous edition of DSM. So, gender dysphoria refer to those persons with a marked incongruence between their experience or expressed gender and the one they were assigned at birth. Persons with gender dysphoria express their discontent with their assigned sex as a desire to have the body of the other sex, or to be regarded socially as a person of the other sex. Next, these are basically the terminologies that will be used throughout this presentation. Firstly, gender identity, which means a sense one has of being male or female, which corresponds most often to the person's anatomical sex. Transgender refer to those who identify with a gender different from the one they were born with, sometimes referred to as their assigned gender. Usually, transgender people do not go for genital surgery as what we always think for, and it can be either they are unable to afford it or simply they don't desire it. And then transgender people also may be of any sexual orientation. They can be lesbian, gay, straight or bisexual. And then transsexual. Transsexual refer to those who want to have the body of another sex. And then gender queer are those who feel they are between genders, of both genders or of neither gender. And lastly, those who wear clothing traditionally associated with another gender but maintain a gender identity that is assigned gender is known as cross-dresser. So epidemiologically, gender dysphoria can be divided into children, adolescents, and adults. In children, parents typically report that cross-gender behaviors were apparent before 3 years of age. The sex ratio of children referred for gender dysphoria is 4 to 5 boys for each girl, probably due to societal stigma directed towards feminine boys. And then in adolescence, the sex ratio is equal, which is 4 to 5 male for each female. Whereas in adults, most clinical centers report a sex ratio of 3 to 5 male patients for each female patient. Overall, the prevalence of male to female dysphoria is higher than female to male dysphoria. An important factor in diagnosis is that there is a greater social acceptance of birth assigned females dressing and behaving as boys, as what we call tomboys, greater than the birth assigned males acting as females. And researchers found that 1 in 500 adults may fall somewhere on a transgender spectrum. Next, moving on to the diagnostic criteria, that can be divided also into children and also adolescent and adults. So as for children, criterion A says that a marked incongruence between one's experience or expressed gender and assigned gender of at least 6 months duration, as manifested by at least 6 of the following criteria, one of which must be criterion A1. So first one, the first, a strong desire to be of the other gender, or an insistence that one is the other gender, or some alternative gender different from one's assigned gender. 2, in boys, a strong preference for cross-dressing or simulating female attire, or in girls, a strong preference for wearing only typical masculine clothing, and a strong resistance of wearing typical feminine clothing. The third one, a strong preference for cross-gender roles in make-believe play or fantasy play. The fourth, a strong preference for the toys, games, or activities stereotypically used or engaged in by the other gender. The fifth one is a strong preference for playmates of the other gender. The sixth, in boys, a strong rejection of typically masculine toys, games, and activities, and strong avoidance of rough and tumble play, whereas in girls, a strong rejection of typically feminine toys, games, and activities such as Barbies, dolls, like that. And for the seventh one is a strong dislike of one's sexual anatomy. And lastly is a strong desire for the primary and or secondary sex characteristics that match one's experienced gender. So next, for criterion B, the condition is associated with clinically significant distress or impairment in social, school, or other important areas of functioning. And then if the person have a disorder of sex development, for example, congenital adrenal hyperplasia or androgen insensitivity syndrome, we need to specify it with a disorder of sex development. Next is the diagnostic criteria for gender dysphoria in adolescents and adults. For criterion A, it is the same as in children. The incongruence occur at least 6 months duration, but it needs only two of the following. The first one, a marked incongruence between one's experience or expressed gender and primary and or secondary sex characteristic, or in adolescence, the anticipated secondary sex characteristics. Second one, a strong desire to be rid of one's primary and or secondary sex characteristics because of a marked incongruence with one's experience or expressed gender, or in young adolescents, a desire to prevent the development of the anticipated secondary sex characteristics. The third one, a strong desire for the primary and or secondary sex characteristics of the other gender. The fourth, a strong desire to be of the other gender or some alternative gender different from one's assigned gender. The fifth one, a strong desire to be treated as the other gender. And the sixth, a strong conviction that one has the typical feelings and reaction of the other gender. For criterion B, this condition also cause a clinically significant distress or impairment in social, occupational, or other important areas of functioning. The same with in children, we need to specify with a disorder of sex development, as mentioned previously, and in addition, specify if post-transition, which means the individual has transitioned to full-time living in the desired gender, not their assigned gender, and has undergone or is preparing to have at least one cross-sex medical procedure or treatment regimen, such as hormone treatment or surgical base, such as vaginoplasty or phalloplasty. Next is the treatment for gender dysphoria. In children, it typically consists of individual, family, and group therapy. The approach will guide them explore their gender interests and identities. There are some providers who provide reparative or conversion therapy, which attempt to change a person's gender identity or sexual orientation. However, this type of therapy is contrary to position statements by the practice guidelines. Next, in adolescents, in addition to providing psychotherapy, many clinicians consider to use puberty blocking medications. They are basically GnRH, gonadotropin releasing hormone agonist that can be used to temporarily block the release of hormones that lead to secondary sex characteristics. Will give adolescents and their families time to reflect on the best options moving forward. And then in adults, treatment for those who identify themselves as transgender may include psychotherapy to explore gender issues, hormonal, and also surgical treatment. So regarding hormones treatment, in transgender men, it is primarily accomplished with testosterone, usually taken by injection every week or every other week. Initial changes include increased acne, muscle mass, and libido, cessation of menses, deepening of the voices, increased body hair, and enlargement of the clitoris. Since testosterone is a steroid hormones, a routine monitoring of liver function, cholesterol, and hemoglobin level should be done. And for those beginning with hormone therapy, they will be routinely counseled on fertility, as future fertility may be affected on the use of testosterone. In contrast, transgender women may take estrogen, testosterone blockers, or progesterone, often in combination. These hormones can cause changes such as softening of the skin and redistribution of fat, as well as breast growth. Sex drive, erections, and ejaculations can decrease in body hair, but there is no change in voice since testosterone has permanently altered the vocal cords. Those on estrogen also should be routinely monitored their blood pressure, liver function, and also cholesterol level. Reproductive counseling is very important because permanent sterility is almost always the outcome.
Okay.
Next.
Sorry, Haziq. Just to interrupt, okay? This hormone treatment, okay, this is for, transgender men means that the women who convert to men. Okay, so this hormone is given to the girl who convert to men, and for the transgender woman is the estrogen to given to a man who convert to the woman. Okay, I think that's the way lah. Betul ke?
Yes, true.
Yes, because uh, before I know this, we thought that transgender man is that the man who want to become a lady. Okay, tapi actually there is for female who want who convert to male, so they will give her testosterone to build up as a male body lah, similar to the transgender women. So in some country, they allowed to practice this because they have some of the NGO to have right for the transgender, but this is not in our country lah. Okay, so this is the general treatment for them. Basically, they will give hormone to build up their desired punya sex lah. Okay, continue.
Okay, next is surgical treatment. In transgender men, they may have top surgery or so-called chest surgery, may have to construct a male contoured chest. And as for bottom surgery, they might choose for metoidioplasty, in which the clitoris is freed from the ligament, attaching it to the body, and tissue is added, increasing its length and girth. Next is scrotoplasty, the placement of testicular implants, and then phalloplasty, which is the creation of a penis. And then transgender men also rarely undergo facial surgeries, whereas in transgender women, they commonly undergo top surgery for breast augmentation. Bottom surgery for women is typically vaginoplasty, also commonly sex reassignment surgery, SRS, or orchiectomies, which is cheaper than the vaginoplasty, where the testes alone are removed. Some may undergo a facial feminization surgeries that alter the cheeks, forehead, nose, and lips to create a more feminine facial appearance. So basically, that's all for gender dysphoria. Moving on to the next part of this seminar, which is paraphilic disorder. Paraphilias or perversions are sexual stimuli or acts that are deviations from normal sexual behaviors, but are necessary for some persons to experience arousal and orgasm. According to DSM-5, the term paraphilic disorder is reserved for those cases in which a sexually deviant fantasy or impulse has been expressed behaviorally. Individuals with paraphilic interest can experience sexual pleasure, but they are inhibited from responding to stimuli that are normally considered erotic. Persons that occasionally experiment with paraphilic behavior but are capable of responding to more typical erotic stimuli are not seen to have paraphilic disorder. Paraphilic disorders can range from nearly normal behavior to behavior that is destructive or hurtful only to a person's self or to a person's self and partner, and finally to behavior that is deemed destructive or threatening to the community at large. So based on DSM-5, there are 8 paraphilic disorder, and they can be classified into 2 big groups. The first group of disorder is on the left side. There are 5 of them. They are called anomalous activity preferences, and they can be subdivided into 2. The first one, courtship disorders, which resemble distorted components of human courtship behavior, such as a voyeuristic disorder, exhibitionistic disorder, and also froteuristic disorder that are colored in blue. And the second one is allogenic disorder, which involve pain and suffering, colored in the red. The example is sexual masochism disorder and also sexual sadism disorder. And the second group of disorders is based on anomalous target preferences. These disorders include 1, directed at humans. For example, pedophilic disorder, coloring, and the other two is directed elsewhere, such as fetishistic disorder and also transvestite disorder. So, epidemiology of paraphilic disorder. Paraphilias are practiced by only a small percentage of the population, but the insistent, repetitive nature of the disorders results in a high frequency of such acts. The paraphilias seem to be largely male conditions, and more than 50% of them have their onset before age of 18. Patients frequently have 3 to 5 paraphilias, either concurrently or at different times in their lives. The occurrence of paraphilic behavior peaks between age 15 and 25 and gradually declines. Paraphilia designation be reserved for those aged 18 and older to avoid pathologizing normal sexual curiosity and occasional experimentation in adolescents. So the diagnosis can be made only when the patient is age 18 and older. And in men older than 50, criminal paraphilic acts are rare. Those that occur are practiced in isolation or with a cooperative partner. Okay, so the first disorder is voyeuristic disorder, or also known as voyeurism or scopophilia. It is defined as recurrent preoccupation with fantasies and acts that involve observing unsuspecting persons who are naked or engaged in grooming or sexual activity. Masturbation to orgasm usually accompanies or follows the event. And the first voyeuristic act usually occurs during childhood, and the paraphilia is most common in men. The diagnostic criteria for voyeurism is as follows. Criterion A stated that over a period of at least 6 months, recurrent and intense sexual arousal from observing an unsuspecting person who is naked in the process of disrobing or engaging in sexual activity as manifested by fantasies, urges, or behaviors. For criterion B, the individual has acted on these sexual urges with a non-consenting person without consent, or the sexual urges or fantasies cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. And for criterion C, the individual experiencing the arousal and or acting on the urges is at least 18 years of age, as mentioned previously. And then we need to specify it if in a controlled environment, which means this patient to individuals living in institutional or other settings where opportunities to engage in this behavior, voyeurism, are restricted. And then the next one is in full remission, in which the individual has not acted on the urges with a non-consenting person, and there has been no distress or impairment in social, occupational, or other areas of functioning for at least 5 years while in an uncontrolled environment, not controlled environment. Okay, the second one is exhibitionistic disorder. It is defined as a recurrent urge to expose the genitals to a stranger or to an unsuspecting person. Sexual excitement occurs in anticipation of the exposure, and orgasm is brought about by masturbation during or after the event. In almost 100% of cases, those with exhibitionism are men exposing themselves to women. The dynamic of men with exhibitionism is to assert their masculinity by showing their penises and by watching the victim's reaction, either fright, surprise, or disgust. And then for the diagnostic criteria of exhibitionism include the first one for criterion A, over a period of at least 6 months, recurrent and intense sexual arousal from the exposure of one's genital to an unsuspecting person as manifested by fantasies, urge, or behaviors. And for criterion B, the individual has acted on this sexual urge, non-consenting person, or the sexual urge or fantasies cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. And then we need to specify whether the individual gets sexually aroused by exposing their genitals to who. First one, to prepubertal children, and then to physically mature individuals, or to both prepubertal children and to physically mature individuals. And as the voyeuristic disorder just now, this can be specified in a controlled environment where the behavior of exposing one's genitals are restricted. And then in full remission, which means the individual has not acted on the behavior on a non-consenting person, there has not been distress or impairment in the important areas of functioning for at least 5 years while in an uncontrolled environment. And then the third one is voyeuristic disorder, or we call voyeurism. Voyeurism is usually characterized by a man's rubbing his penis against the buttocks or other body parts of a fully clothed woman to achieve orgasm. At other times, he may use his hands to rub an unsuspecting victim. The acts usually occur in crowded places, particularly in subways and buses. And then those with voyeurism only experience sexual gratification based on the frottage, which means rubbing action. And then for diagnostic criteria, for criterion A, over a period of at least 6 months, recurrent and intense sexual arousal from touching or rubbing against a non-consenting person as manifested by fantasies, urges, or behaviors. For criterion B, the individual has acted on the sexual urge with a non-consenting person, or the sexual urge or fantasies cause clinically significant distress or impairment, social, occupational, or other important areas of functioning. And the same as the previous disorder, we need to specify if in a controlled environment where the opportunities to touch or rub against a non-consenting person are restricted, and then in full remission, in which the individual has not acted did not do this behavior on a non-consenting person, has not been in distress or impairment in important areas of functioning for at least 5 years while in an uncontrolled environment. So I will pass this presentation to the next presenter. Thank you.
Okay, Assalamualaikum and good afternoon to everyone. So I'm going to present 5 disorder under paraphilic disorder, which is the fourth one is the sexual masochism disorder, which is a condition in which a person derives sexual gratification from being subjected to pain or tracked to the pain. Masochism is derived from Austrian novelists whose characters derive sexual pleasure from being abused and dominated by women. It is resulted from destructive fantasies turned against self. It is more common in male rather than female, and patients usually may have childhood experiences that convince them that the pain is a prerequisite for sexual pleasure. 30% of the patient have sadistic fantasies, and some allow themselves to experience sexual feeling only when punishment for the feeling follows. The 3 main characteristics of masochism is pain, loss of control, and humiliation. Okay, next. So this is the diagnostic criteria from the DSM-5. So it is over a period of at least 6 months, but the recurrent and intense sexual arousal is from the act of being humiliated, beaten, bound, or otherwise made to suffer. And for criteria B, the fantasy, sexual urge, and behavior cause significant distress or impairment. And then for the specifier, we have 2. The first specifier is with X as physiophilia, if the individual engages in the practice of achieving sexual arousal related to restriction of breathing. And the next specifier is same with the previous, which is either in a controlled environment and also in full remission. Okay, next slide. Okay, so this is the fifth disorder, which is sexual sadism disorder. It is named after Marquis de Sade, an 18th century French author and military officer who was repeatedly imprisoned for his violent sexual act against women. It is intentionally infliction of pain on another person or the threat to do so for sexual excitement. The act may be symbolic, causing little actual harm. However, at times, serious injuries are caused, including severe act of mutilation in a murder. In these rare cases, ejaculation may occur during the sadistic act or later during intercourse with the dead body. We name it as necrophilia. Sexual sadism require a partner to enact the sexual fantasies. It is different when compared with sexual masochism, which does not necessarily need a partner. The onset usually before age of 18 years old and mostly are male. Based on psychoanalytic theory, sadism is a defense against fear of castration. Hence, they do to others what they fear will happen to them and derive pleasure from expressing their aggressive instinct. Sexual sadism as the predominant sexual practice is uncommon, but sexual sadism as a part of normal sexual activity has an estimated prevalence of 3 to 20%. Next is the diagnostic criteria from DSM-5. So as usual, the criterion A, at least 6 months, but the recurrent and intense sexual arousal is from the physical and psychological suffering of another person. For the criterion B, the individual has acted on the sexual urge with a non-consenting person, or the sexual urge or fantasies cause clinically significant distress or impairment. The specifier is the same. Okay, next disorder is the pedophilic disorder. So, pedophilic disorder is a fantasies involving sexual activity pre-pubescent child or children. Most child molestation involve genital fondling or oral sex. Uncommon is vaginal or anal penetration, except in cases of incest. The perpetrator are concomitantly or have previously been involved in exhibitionism, voyeurism, or rape. Most of the victims, 60%, are boys. Estimate of the prevalence of pedophilic disorder range from 1% to 5% in the male population. Pedophiles usually choose a child aged 6 years and puberty, but some prefer very young children. The child may be of the opposite sex or the same sex. Some pedophiles approach children within their extended family or in their professional care, while others befriended unrelated children. It can occur in all ethnic and socio-economic groups. Okay, next slide. So this is the diagnostic criteria from the DSM-5. So for criterion A, as usual, at least 6 months, but the recurrent and intense sexual arousing fantasies, a sexual urge or behavior involving sexual activity with a pre-pubescent child or children generally aged 13 years or youngest. For the criterion B, the individual acted on the sexual urge or the sexual urge of fantasies cause marked distress or interpersonal difficulty. For the criterion C, the individual is at least age 16 years and at least 5 years older than the child or children in criterion A. Do not, for the note, it do not include an individual in late adolescence involved in an ongoing sexual relationship with a 12 or 13-year-old. For the specifier, we have to specify if it's an exclusive type in which the individual only attracted only to children, or non-exclusive type. The next specifier is if the patient are sexually attracted to male or female or both, and the last specifier is it limited to incest. Okay, next is the fetishistic disorder. It is when a person feels a strong recurrent sexual attraction to non-living objects. The sexual focus is on objects that are intimately associated with the human body or on non-genital body parts such as shoes, gloves, stocking, underwear. Contact with the object causes sexual excitement, which may be followed by solitary masturbation or by sexual intercourse that incorporates fetish. The disorder merges into normal sexual behavior but is considered to be abnormal when the behavior takes precedence over the usual pattern of sexual intercourse. It usually begins by adolescence, in some cases during childhood. Once diagnosed, the disorder tends to be chronic. The disorder is exclusively found in men. The estimated prevalence is 1 to 18% in men. The fetish serves as a symbol of the phallus to person with unconscious castration fear. Learning theorists believe that the object was associated with sexual stimulation at an early age. Next is the diagnostic criteria from DSM-5. So for criteria A, it is at least 6 months, but the recurrent and intense sexual arousal is from either the use of non-living object or a highly specific focus on non-genital body part. For criterion B, the fantasy, sexual urge or behavior cause clinically significant distress or impairment. For criterion C, the fetish objects are not limited to articles of clothing used in cross-dressing or device specifically designed for the purpose of tactile genital stimulation. For the specifier, we have to specify if it's only for body part or non-living object or others. And the next specifier is the same as previous, in a controlled environment or in full remission. Okay, next is the transvestite disorder. Transvestite disorder, also known as transvestite fetishism. Transvestitism is to wear the clothing of opposite sex. Some men with this disorder wants to dress and live permanently as women. However, when not dressed in women's clothes, men with transvestitism may be hypermasculine in appearance and occupation. It begins in childhood or early adolescence. It is more common in male rather than in female, and the prevalence is estimated to be around 1%. Okay, next is the diagnostic criteria from the DSM-5. So for criteria A, it is at least 6 months, but the recurrent and intense sexual arousal from the cross-dressing. And for the criterion B, it causes significantly distress or impairment. And for the specifier, we have to specify if it is with fetishism, in which the patient is sexually aroused by fabrics, materials, or garment, or with autogynephilia, when the patient is sexually aroused by thoughts or images of self as female. And then the next specifier is the same as before, in a controlled environment or in a full remission. Okay, next is the treatment. So according to the Kaplan, there is 5 psychiatric interventions that we can do, which is the first one, external control, reduction of sexual drive, treatment of comorbid condition, cognitive behavioral therapy, and also dynamic psychotherapy. I will explain more on the next slide. So for the external control mechanism, prison is for sexual crime that usually does not contain a treatment element. We can also inform supervisor, peers, or other adult family member of the problem and advise them about eliminating opportunities for the perpetrator to act on the urge. The next is treatment is psychotherapy and behavioral treatment. For under the psychotherapy, we have cognitive behavioral therapy, which is to disrupt learned paraphilic pattern and modify behavior. The intervention includes social skill training, sex education, cognitive restructuring, and also development of victim empathy. For the cognitive restructuring, it is when confronting and destroying the rationalization used to support victimization of others. And then we have imaginal desensitization, relaxation technique, and learning what triggers the paraphilic impulse so that the stimuli can be avoided. Next is the insight-oriented psychotherapy, in which to understand, patient will be able to understand their dynamic and event that cause paraphilia to develop. It is a long-standing treatment approach. Okay, for the pharmacological treatment, it is used to treat underlying comorbidities such as antipsychotic and antidepressant if patient has underlying psychiatric illness. The next is anti-androgen, in example, Depo-Provera and criproterone acetate, which may reduce the drive to behave sexually by decreasing serum testosterone level to subnormal concentration, and also the serotonergic agents such as fluoxetine. It used with limited success in patient paraphilia. Okay, next is the prognostic. So there are a few good prognostic indicators. The first one is presence of only one paraphilia disorder. The second one, patient has normal intelligence. The third one is the absence of substance abuse. The fourth one is the absence of non-sexual antisocial personality trait. And the fifth one is the presence of a successful adult attachment. However, paraphilic disorder remains significant treatment challenges even under these circumstances. So that's all from me. Thank you.
Okay, thank you. I know. Okay. I believe that most of you macam mana uh, have poor concentration towards the end of the presentation because so many disorders. Okay, but okay, just want to reassure you, what we need to know at this level is about the name of the sexual disorders. Okay, and try to imagine or remember the actually the main features of each sexual disorders. Okay, for example, for apa dia apa last kali ni paraphilic disorders. Okay, so ada 8 of paraphilic disorders. So each name of the paraphilic disorders tu, imagine the clinical features. For example, voyeurism, okay, apa tu, pedophilia, apa tu, that's okay. That's only what we need to do at this level lah, and what I expect, because if I don't need to concern about the management in detail because that is beyond, even for my level also it is beyond. It is for the subspecialty lah. Okay, so I don't want to explain more about the disorders. Okay, you can review the record of this presentation and just go through and get the name and also the main features of each disorders. Okay, in MCQ there will be a few questions relating sexual disorders lah. Okay, in our 3 main topics just now. Okay, and for example, paraphilic disorders, you still need to know all the disorders, because in MCQ it can be the question asked about the clinical features of that disorder. For example, match in proturistic disorders. Okay, the main features was apa? So in one question tu maybe 5 option, 5 of disorders that you need to know. So nak tak nak memang you need to know lah all the disorders. Okay, but only 1 or 2 questions lah in MCQ. Okay, I also not having a lot of info regarding these disorders because one is a lack of experience, because not many patients will come to our clinic lah for these disorders. But sometimes we get referral to see the patient from other department, but very limited experience. Okay, any question? Okay, if no questions, okay, so this is the last session with me. Okay, so firstly, thanks for the presenters for all my sessions. Okay, second is I want to apologize if anything that that is unpleasant during a session with me. And hopefully good luck for your other postings, and insyaAllah kalau umur panjang kita akan jumpa lagi next year. Okay, thank you. So I will end the session.
Thank you so much.
Thank you, Doctor.